My name is Tom Maddox. I'm a cardiologist here at WashU, and I'm the executive director for the Healthcare Innovation Lab. And I'm thrilled, along with my colleague Philip Payne at I2DB, to host the seventh Big Ideas competition. We have had six cohorts to date compete and win in this competition, and we've had a variety of just wonderful ideas that have started here and really moved into some really impactful things operationally, academically, and even from a commercial point of view. So we're excited to have our next competition and add a seventh cohort to this program. We'll have our team presentations, and then we'll have some closing comments from Philip. So everybody in this room and those of you online, you are participants in this process. We have teams to present their ideas today, and we want your input. So for those of you both in the room and online, please scan the QR code, and that'll take you to our voting site. And what you'll see here is that for each team, we're asking you to consider the quality of their approach in four different domains. One is its clinical applicability. We want these to be very applied in what we do. Two is feasible. We want to make sure this isn't, an Elon Musk get to Mars in the next year kind of thing. Three is it really innovative? Is this just a really new approach, a novel approach? And then finally, team composition. We know that nobody can do things individually, particularly in healthcare. And so is the innovation that the team is proposing, do they have the right kind of team members and skill sets on their team to realistically execute on their idea? And as you'll see, it's a rank in each of these four categories, 1 being the lowest score, 10 being the absolute best. This will be an input into our overall evaluation of the ideas. All the teams, in addition to today's presentation, have also prepared a full-length application, getting a lot more detail about what they're going to do. And what we're doing is we're taking your input as the audience. We also have our judges here in the room, who I'll introduce in a minute. We're going to get their input. They'll also have the opportunity to question the teams after their presentation. And then finally, we have a separate team of judges who are reviewing the written applications. We'll be taking all that input and then deciding the top six that will get the $50,000 award each and the year of support to try and make their idea into reality. So that should be hopefully clear about the process. And as you can see, the link is in the chat for those of you who are attending the competition virtually. So the Big Ideas program, as I said, has been around since 2018, a joint effort between the Innovation Lab and I2DB. Over this period of time, we have awarded in total $1.8 million to 36 different ideas. And these ideas have been shepherded by collectively 115 investigators. And they've resulted in a lot of academic output, 115 publications and abstracts to date. And every month we get further evidence of some of the academic production of these projects. We often ask that this idea be pilot data that supports further investigation into the idea, knowing that it's rare that you're done developing that idea after 1 year. So we've seen that there have been multiple grant submissions based on the pilot data from this year's worth of work, and it's resulted to date in 12 funded grants. And then we've had commercialization even. We've had 2 patents come out of some of the work these teams have done. So we've also had, we don't have it listed here, but we've also had several of these ideas move into operation. So some of the care we provide to our patients daily is done in part with some of these innovations that the teams have developed over the years. So I think it's a really exciting program that surfaces the really cool ideas amongst our faculty and employees and can apply them in all the different domains that a school of medicine and a health system has to improve patient outcomes. So very happy with the program to date, excited to add today's ideas to this mix. So we certainly want to thank the judges that we have in our room. They're listed here, and just really appreciate their perspective and expertise in weighing the value of these grants and proposals that we have in front of us today. Most of you know them, but we have Vicki Frazier, who's our chair of medicine. We have Nicole Mercier, who runs our Office of Technology Management. We have Teresa Eggman, cleverly disguised as Charles Albach here at the table. Both Teresa and Charles are part of our Epic One team. Teresa's been ill, so she's calling in remotely, and Charles has kindly agreed to stand in her place physically. Angeline is both our Chief Operating Officer and our Chief Nurse Executive, now at West County. President of West County and operating officer here, right? Because why do one job when you can have two, right? So obviously thinks very deeply about hospital operations as well as our nursing corps. And then John Lynch, who's the president of BJH and also a pulmonologist, so can provide perspectives on both. So again, greatly appreciate your input in today's competition. So with that, let's move to the first team and we'll get things going.
Okay, thank you very much. So my name is Shuo Wang, so from radiology. So it is my great pleasure to present our project. So about autism early diagnosis using home videos and foundation models. So this team includes me and Dr. John Pruitt from Department of Psychiatry. So as you know, so approximately 1 in 36 children in our society is diagnosed with autism spectrum disorder. So the average age for the child to be diagnosed is about 4 years. However, early diagnosis can greatly help to improve their symptoms. So basically, there's a very big gap in the age of their diagnosis and also the emergence of their symptoms. So the overarching goal of our project is to facilitate early diagnosis of autism by using the home videos as well as quantitative, objective, and comprehensive AI models for the video analysis. So we will address two specific aims. In the first aim, so we will develop and validate a novel framework in order to get the home videos. In the second aim, so we will develop the latest foundation foundation-based models to analyze these videos. So in our preliminary testing, so basically we have already done this for about 5 years. So in our preliminary testing, so we plan to have 16 to we plan to get 100 children, so aged between 16 to 36 months. So there will be two groups. In one group, that is controls, so no neurodevelopmental disorders. So for the autism group, so we will focus on those kids with already a diagnosis. So basically, we will recruit participants from our autism clinic so that we know their ground truth. For the experimental design, so we have already implemented this. So basically we have 9 tasks. So the tasks are very detailed. So based on the autism domain knowledge. So there are some from the clinic perspective. So we know how to correctly elicit the autism symptoms. So that's why we give these instructions to their parents. So based on these instructions, so the parents can have their children to do these tasks. From our preliminary results, so we can, so the first thing we want to show is we can collect videos. So basically the parents can use our instructions, can participate in this study and can give our correct data. And then we want to show that, so the parents can follow the instructions and the child can also follow the instructions. So they can demonstrate the behaviors that can be analyzed. So lastly, so we have 2 autism experts to go through all the videos. And then we also designed some criteria to evaluate these videos. And then as you can see over here, so they will have very high consistency in evaluating these videos. Basically it means, so the parents, the children, so all follow the instructions and can elicit the correct behaviors for our next step of the analysis. So as many of you may know, to use the recent AI models, generative AI models, like for example, like ChatGPT, or this is more in-depth to directly analyze videos. So one very important thing is to design the prompt. So basically, so these AI agents, so they are very powerful, but you need to give them the correct instructions. So you need to tell them what to do, and so that they can return the correct answers. So we spend a lot of efforts in order to tune the AI models. So for example, we tell them what they're supposed to do. Basically, we give them the task instruction, and then we give them the what they are looking for. So these kind of the features, so they should pay attention to. So give them a list of the features that based on the domain knowledge from autism research. So we give them this structured input, and also we tell them the task. And one very important thing is that, so a lot of these AI models, so they have hallucinations. So we don't want this false positive, so that we keep on kind of restricting their behaviors to focus on the correct things. And lastly, we specify the output from these AI models. So for example, we tell them to give us the relevant information, so they can tell us at which point so the child does what. I'll give you a few examples. So this seems very promising. So this is a video. So it's kind of in the wild home environment. So the parent asks the child for the attention. So as you see, we took the video about 1 minute. So then we input this model to the AI agent, so the agent can return the things like a clinician. So basically, so this is I think this is a child without autism. So basically, the parent asks for the attention, as you see over here. So the AI found that the child has eye contact with the parents, so there's the social attention detected, and also when the parent smiled to the child, the also child smiled back. So all these can be detected from this video. So I see this video is quite complex, and also it's not like the previous research. It's very so the video is can be in the cluttered home environment. So another case for a child with autism. So in this case, so the AI model, so the parent asked for the attention of the child, but the child didn't respond. So in the first case, so they said the child doesn't have the eye contact with the parent when their name is called. And then for another occasion, so the AI also correctly detect the behaviors. But also basically we go through carefully of the AI performance, we detect the errors, and also we try to correct the AI for their incorrect judgments. So they become better and better, more and more powerful for analyzing these videos. So basically we have the correct videos, and also the AI can do the correct thing. For the next step, so as I mentioned, so the AI is not perfect. So we still need to better tune the AI in order to get to be, so it's like you train a clinician, so the AI should also be trained, so then they can work better and better. So of course the more the data, the more data, the better. That's why for these big ideas, we would like to use the funding to get more data from more families and from the people with more diverse backgrounds. And then, so we're also working to apply for our R1 grant from NICHD, and also we're writing for a patent of this approach. So lastly, I want to mention the collaborations. So this is, I think it's a good collaboration between myself. So I'm a cognitive neuroscientist, cognitive and computational neuroscientist, and also a biomedical engineer. So this is in collaboration with Dr. John Broad. So he's a clinician scientist at WashU, and also this is supported by a computer scientist, Professor Xin Li from University at Albany. So thank you very much for your attention. So any questions? Yes, please.
Does your model incorporate known autism risk factors like premature birth or physical prevalence or populations and other more prevalent analysis? With that, oh, sorry, I could have waited for the microphone. But did you hear me okay? Or would you like me to repeat the question?
Probably better with the.
Sure, absolutely. Oh, sure. Hi, everyone online. I wondered if your model incorporated known risk factors for autism, like prematurity, or if it incorporated population factors like being male versus female.
Yeah, that's a good question. So we do not specify that directly to the model because we don't see much difference in the model's performance with these factors. But our sample size, as I mentioned, is only 42 children. So we still focus on the individual data at this moment. So I haven't done much of the group analysis.
Thank you.
Population analysis.
Quick question here, Dr.
Yes.
Wong. Congratulations on your early work and data to date. Your task list, is that a recognized in sort of the diagnostic evaluation of
What?
is that a recognized list of tasks that is commonly used in
Yes, yes,
diagnosis?
yeah.
And is there overlap with other potential syndromes?
Yes. Yeah, good question. So basically, so our design, so for autism, so there's a research diagnosis task. So it's called ADOS, Autism Diagnosis Observation Schedule. So that one is 1.5 hour long. So then this basically want to look at kind of all the autism behaviors, but that is performed by the clinicians, not by the parents or by people without this very intense training of autism. So that is done with kind of very intensive training. So then not so many people have that certificate. So based on those, but we base our design on those criteria. So basically they look for the social attention. So then we have a simplified task that can be performed by the parent, but still look for the social attention. So the criteria is totally based on the autism domain knowledge. So there are several kind of deficits in autism so that people should look for. So we design our tasks based on those. Yeah.
I'm curious about
Yeah.
your patient or participant recruitment
Mhm.
and thinking about things like differences in the home
Yeah.
and those types of influences on the videos and the responses you might get.
Yeah. So the yeah, of course there are, so different families have different different style. So then there's there are some variety in their respondents. So there are some parents prefer to do all the tasks at one time, and some parents only do one or two, and then there's some dropout as well. So there's a great variety, but we kind of after collecting some data, so we know how to approach the family and then how to kind of increase our success rate. So we try to simplify our instructions and to better engage the families. But that's the kind of getting the families to work on this is very important. So, but yeah, we spent kind of the first few years to figure this out. But I think everything is working very well now. Okay, thank you very much.
Good afternoon, everyone. My name is Ahmed Saeed, and I will be presenting our team's proposal on AI-driven predictive models for precision anticoagulation in pediatric ECMO. So extracorporeal membrane oxygenation, or ECMO, is a life-sustaining form of bypass that we use in the ICU for children with severe heart and respiratory failure. It involves draining the blood from the patient's body into the foreign ECMO circuit where oxygenation happens before it returns. The exposure of the patient's blood to the ECMO circuit then increases the risk of clot formation, so we have to use systemic anticoagulation on these patients. That then puts us in that fine balance of trying to minimize the clot formation in the patient in the ECMO circuit while minimizing the risk of bleeding, both of which could be catastrophic. Currently, anticoagulation management depends on a set of in vitro labs of the patient's coagulation status. Unfortunately, these labs are lagging and do not correlate with either the anticoagulation medication dosing or real-time patient outcomes. So we're left as clinicians with a heuristic lab-dependent reactive approach that doesn't really represent the evolving physiology of the ECMO patients or the different risks for bleeding and thrombosis in different patients. This was recently emphasized in a 2024 Peace Collaborative that I was fortunate to participate in, where we evaluated over 3 decades worth of pediatric and ECMO anticoagulation literature, and we concluded that there are no standardized monitoring tools that we could use for all patients, and that the complex interaction of the patient, the ECMO circuit, the underlying physiology, coagulopathy, and anticoagulation medications necessitates a more comprehensive approach. So we're proposing that machine learning models that incorporate the high resolution data of the patient characteristics, ECMO variables, anticoagulation medications, and laboratory data can accurately predict the risks of bleeding and thrombosis in pediatric ECMO patients. This then gives us the potential to shift from a lab-guided reactive approach to more of a predictive real-time decision support. To do that, first we'd have to establish data pipelines that extract and transform the necessary variables for the input and outcomes for the models. develop machine learning predictive models for the first and repeat incidences of thrombosis, and also develop machine learning models for the first and repeat incidence of breathing complications. So the models we're proposing would include the static patient characteristics, ECMO variables, and underlying pathology, in addition to the time series evolving coagulation medications, coagulation labs, medication interactions, and the interactions with the ECMO circuitry, providing a dynamic risk prediction of both bleeding on ECMO and thrombosis both on ECMO and after. These models will be based on prior work that we've done. So we've been able to establish a pretty comprehensive, continuously updating pediatric critical care data mart. The data mart we have is able to extract all the discrete EHR variables for all our ICU patients and couples that with all the high-resolution telemetry data directly extracted from the bedside monitors. It also includes ECMO patient-specific data, so we have ECMO variables that are not otherwise present in discrete EHR fields and ECMO patient-specific outcomes. This data mart will serve as the source for the variables for the ECMO models. We also performed a preliminary analysis of developing a predictive model to identify the first incidence of thrombosis in a select patient population. So we use a simplified approach that kind of mirrors what we do right now, depending on just anticoagulation medications and coagulation labs, and that model had a pretty poor predictive performance. We then compared that with a more comprehensive model that used both static and time series variables, and even though the model had modest performance, it outperformed the current approach. So we then envisioned that these models would be built into the EHR order sets, providing clinicians with a continuously updating risk prediction every 4 to 6 hours to mirror the half-life of the anticoagulation medications and the frequency that we get these labs. This decision support tool, as embedded into the ECMO order set then, would guide clinicians' anticoagulation titration based on individualized, continuously updating risk estimates. Next steps, we would apply for extramural funding for prospective validation of the models first in a background EHR environment, to then develop prototype decision support tools that we would iteratively refine based on clinicians' feedback, and then identify the impact of these models on clinical decision-making and patient outcomes. To do this work, we've established a comprehensive team with expertise in pediatric critical care, ECMO, computer engineering, and computer science. And thank you for all the attention, and I'm really excited about the ability to transform how we manage pediatric ECMO anticoagulation, and I'm happy to take any questions.
Can you clarify how many patients you currently have, the sample size, and then how standardized is the current anticoagulation regimen for these patients?
Yeah, thank you for that question. So our data mart goes back to the rollout of EPIC. So we have patients since mid-2018 in our data mart. For the ECMO patients, we have over 350 ECMO patients. We're considered one of the pretty high pediatric ECMO centers. So we do about 60 ECMO runs a year. And we have over 350 patients right now. From the ECMO anticoagulation guidelines, so I didn't really include a snapshot of our current guidelines, but we've tried to mimic this approach in a non-data way. So we have a guideline that try to stratify the patients based on standard bleeding and thrombotic risks, high bleeding risks and high thrombosis risk, to kind of give clinicians guidance on which direction to titrate their anticoagulation. But despite that, it's not really based on true data that really provides objective guidance to the clinicians.
Hi. Like you mentioned, very tight, thin line between bleeding and thrombosis with ECMO. So what happens when your models give you, you mentioned your aim 2 and 3, one's risk of thrombosis, one's risk of bleeding. What happens when there's conflicting information, or when one's pushing you one way where clinically maybe it's not, the right thing to do?
Thank you. That's a great question. So I guess that goes back to the principal dogma of clinical informatics, right? So we're providing another piece of objective data for the clinicians to make that decision, not to replace the decision making, but to augment their decision. Right now, we don't have any guidance to help us weigh that balance of the risks of bleeding or thrombosis. But if I'm able to provide clinicians with a tool that tells them that the risk of bleeding is, say, 60%, while the risk of thrombosis is 10%, then that helps us make that decision at the bedside. So something to augment that decision making, but not really to replace it or to tell us what to do.
Hi, thank you. So can you elaborate a little bit about how the prediction and the decision making it is performed in a real-time fashion?
Thank you. So in real time, it's a very reactive approach. So I have to wait till someone tells me, hey, the ECMO circuit has more clots on it. We need to titrate our anticoagulation right now. So I'm trying to catch up with the patient's evolving status or that the patient's actively bleeding. So I need to come down on the anticoagulation. There's nothing right now that can help me kind of predict which patients are truly at high risk of a specific outcome versus the other. I know that there are some general categories, say a patient who just had open heart surgery, that patient would be at high risk for bleeding, but how much does the open heart surgery play into that? I don't have a way to quantify that risk.
To what you had before without the system?
So thank you. Yeah. Yes, so the database gives us the ability to have a retrospective control group and a prospective then validation group that we can compare to the retrospective group.
How will you control for whether people accept the algorithm or provide different order sets based on what the algorithm predicted?
Thank you. Yeah. So first, we would prospectively validate the model itself in the EHR background. So it would be blinded to clinicians and we'll see how the model performs in a prospective fashion. And then when we roll out the prototype, we get clinicians' feedback and show them the data on how the model performs in the background to validate the model itself. And that will help us then get the buy-in from the clinicians. Once the order set, once the model is in the EHR, then that data is available in the EHR, and we can quantify then how that influences people's decision-making or not, because it will be part of the data that's available in the EHR.
We are currently facing a radiologist shortage with far too many scans and too few radiologists. Over the last 10 years, there's been an 80% increase in imaging volume workload per radiologist. And this shortage is projected to grow with a 22 to 50% increase in scan volume over the next 30 years, while the number of radiologists is going to stay relatively constant. Similarly, at Barnes and Children's, we've seen a 30% growth in imaging volume in the last 5 years, and Barnes has needed to invest an estimated $20 million in annual workforce salary in radiologists to meet this demand of imaging volume. As Barnes continues to grow, our shortage of radiologists will also likely continue to grow. This shortage of radiologists leads to radiologist burnout, which has several downstream negative impacts on patient care, including delays or incorrect diagnoses, delays in treatment, and longer lengths of stay. While there are other solutions to the radiologist workforce shortage, these will likely take years. We are all radiology residents, and we chose to focus on what we can improve now and also what we know best, which is improving efficiency of radiology workflows. These workflows basically involve chart review, image review, and report generation. And of these, we chose to focus on chart review. This task is very important to our workflows as it greatly improves our diagnostic confidence and accuracy, but at the same time, it's very inefficient. As you can see here on screen right, we have an oncology note, and we have to dig through large swaths of text to find relatively few pieces of information highlighted in red, akin to finding needles in a haystack.
Right. So our solution is to create an automated AI system that performs chart review for radiologists. And we're focusing on cancer patients, given how complex their histories are and how often we image them here. So for any given patient, we extract relevant data from the EHR and feed this to our large language model pipeline, which is completely secure. That pipeline generates a clinical summary that was created with input from over a panel of 15 radiologists. And it essentially consists of clinical parameters that they wish they had at the time of imaging interpretation. So I actually have a demo here for you, and you could see with a single click, we launch our AI system. And in moments, we have all of these clinical parameters that help us confidently and accurately make interpretations. And it just takes a few seconds. And I'll show you one more example here. Now, while this is processing, I just want to mention this takes all recent pathology, surgery, radiation oncology, and radiology reports and distills them into this summary. Now, even the fastest radiologists cannot consolidate that amount of information this quickly. So we are residents, we are the end users of this tool ultimately, and we're really happy with how easy this is to use with its single click generation and how fast this is. But I really want to highlight the innovation here. We are using cutting edge principles in AI systems design to make sure our summaries are consistently structured. And further, our framework is extremely flexible. So we can modify this tool very easily and expand it into areas beyond radiology. Also, if a new language model comes out that's more powerful and more accurate, we just change a single line of code to integrate it into our system. Last but not least, this is secure and scalable from end to end, so we can get this into the hands of our radiologists.
So we tested this on retrospective data, and our tool completed chart review in under 13 seconds, saving almost 4 minutes per study. We had very promising initial results with very high factual accuracy and completeness scores. When translating that to BJC, each radiologist could save up to 1.5 hours in clinical chart review time per day. And translating that to the enterprise, that means we could increase profits by $27 million when you translate it to all of the BJC system. Our next step is to translate this into a prospective pilot, which has already been approved by the WashU IRB. We plan to use a human-computer interaction system to use mouse tracking and eye tracking to assess impact on radiologist workflow. This can generate novel insights into the radiologist AI interaction.
We're all radiology residents, so we deeply understand the problem. I'm Govind Mate. I'll focus on trial design, operations, and regulatory. I have a research background from the NIH and the FDA. I also have a business background with the Wharton MBA, and I worked in industry translating basically health tech devices across healthcare systems.
Hey, I'm Curran. I'm focusing on systems design and software engineering, as well as deployment of this tool. I have about 10 years of experience developing clinical AI at places like Columbia, Harvard at MGH, and here at WashU. I've bootstrapped AI ventures in medical simulation training and have served as a consultant for multiple health tech and radiology AI startups.
I'm Shez, I'm Radiology Chief Resident and Informatics Fellow. I have software development experience at Epic and developing other medical platforms. I'll be leading integration of this tool into the clinical workflow and also tool performance metrics. We're backed by several radiology leaders, including the Associate CMIO and the Vice Chair for Quality and Safety. Our stakeholders have seen our product since day one and have expressed enthusiasm and support. We've also already partnered with WashU IT and the radiology technology team at large. Here are our references, and thank you for your time.
So I have a naive question. Other than the security factor, why couldn't you use something like ChatGPT to pop in a bunch of different charts and just pull out what you're commonly seeing?
So a lot of our system, a lot of that actually relies on prompt engineering, but we've moved away from prompt engineering. And in the way that you put in a phone number online and it verifies, yeah, this is a real phone number, we're actually verifying the outputs of the language model's data. So it will give us that structured summary. We're not having to prompt it and ask it, oh, please extract the radiation oncology history, please grab all the chemotherapy. So our system actually puts up guardrails for the language model. And then that allows us to make these bulk requests, whereas, and it's, again, you mentioned the security, but that's really where it differs from just asking ChatGPT. A lot of what you'll see here today, ultimately does use a large language model backbone, including, the prior presentation on foundation models. So, but that's the big difference.
Congratulations. Great presentation. First, your first commercial target should be every medicine intern in the country that has to do the same task with thick charts. Along the same lines, how do you, what questions are you really looking for clinical significance in reading radiology studies? How is that built into your system?
Yeah, sounds good. So basically, we surveyed all the radiologists who are interpreting thoracic and abdominal oncology data, and then we put that together. So to give you a very tangible example, we specifically look at whether patients currently on systemic therapy, when they receive radiation therapy, what cancer they have, because all of that very greatly influences the way that we read the study. So to give you one example, one thing we deal with all the time is with a lot of these new immunotherapies is deciding whether someone is truly progressing in terms of their disease or if it's pseudo-progression, because some of these systemic therapies can cause lymphadenopathy, making them look more hot on PET. That's not actually real disease. That's just the drug working. So if we hadn't gotten that clinical information that this patient's on immunotherapy, we might easily call progression that patient fall off a clinical trial and have a huge negative impact on their care. But if that piece of information is right there at the right time, the radiologist says, hey, they're on immunotherapy, this could be pseudo-progression, that greatly changes the patient's outcome. One other common example, one of our the team members is Andy Bierholz, who's a thoracic radiologist, differentiating basically when a patient has lung cancer and they get radiation, differentiating radiation fibrosis from progressive disease is also very, very challenging. Both of them look identical in imaging sometimes. They can have ground glass opacities surrounding the primary mass. But if you know that, hey, they got radiation 3 months ago, then you can say this is more likely radiation fibrosis. And therefore, the oncologist can see that and say, hey, we don't necessarily need to take this patient off the current trial or the current drug they're receiving. We can continue the course.
A lot of your innovation is really understanding the problem that you're serving, but make sure that you can include that in your presentation because you're talking about, chest oncology patients. I'm an otolaryngologist, probably doesn't apply to me that much. I would be very interested in a similar model that looks at the things that I'm interested in, but it would be a different model. So when you're doing your projections of, hey, if we expanded this to the whole system, you really don't have a model that expands to the whole system yet. You're tuning appropriately the model that's looking at the system you've got now.
To just quickly address that point, totally agree with your point. But again, we are steering these models. So we actually have many patients with synchronous lung cancer and head and neck cancers. And you can speak to the evaluation, but we're able to accurately capture the summaries of their treatment course for the head and neck cancers in this current system. So again, we tried to maintain that flexible framework and rather than relying on prompt engineering and a one-off solution, have something that could very quickly expand to other use cases just by kind of adjusting the guardrails. So we're not fine-tuning any models here. We can be very nimble.
Thank you for the great presentation. I have a question about the metrics that you're using as a effective, the evaluation metrics for the framework you are presenting. So how do you measure the quality of the discharge summary? So for example, when I'm a radiologist, looking at those pictures, I'm thinking that you can provide me with a summary that I don't have to look at the exact data, but drawing some conclusions from that vast amount of data. Because you was mentioning you have 95% accuracy of the framework. If you are just pulling the data from the database, why not a rule-based system, but a large language model?
Yeah, so unfortunately, every single patient is different, and we have several patients with multiple different primaries. So when we're grading the accuracy and completeness scores, we went through every single data point and graded whether or not this is actually accurate to the current cancer that is being treated. So for example, we have patients with synchronous lung cancers and head and neck cancers. But the systemic treatment that they're on could be for the head and neck cancer rather than the lung cancer. And we have to accurately categorize that for each primary cancer. So the few points that we lost in accuracy was actually because one of the systemic therapies was not categorized to the appropriate management of the appropriate cancer. So when you're looking at that, having something that's flexible to each individual cancer is very important. And, that's why we had to do it the way we did.
And just to kind of follow up on that point, the status quo of the histories we currently get is just metastatic disease. And as Govind pointed out, we are, really overloaded with work. So it's actually difficult, to stop and ask that question and go get that answer. As you saw, almost 95 to 96% reduction in time of going and fetching that information, but with a potentially significant impact on the patient care.
And then the last little piece I want to add in about the manual evaluation that we did, we looked at like over 1,000 data points for all of our different patients. So we graded these probably harder than we've looked at a lot of the LLM literature out there, and we graded it harder than most of these literature models out there. Most of the other models just kind of have a Likert score and say, okay, do you kind of agree with the summary? Out of score out of 10, like how accurate do you think it is? It's like these subjective metrics. We actually went point by point with over 1,000 different metrics and said, this is right or wrong. And we were very harsh in our model. And like even slight little variations, we counted as, like, okay, that's not a complete score. So any tiny little deviation from 100%, you just have to have that in mind. We're being very harsh and probably harsher than most of the other evaluations out there.
And sorry, a last point to the metrics, because I think it's so important. We're actually in the process of developing internal metrics and benchmarks because, these new models are coming out. OpenAI, they just released a new set of models, but we essentially want to be able to benchmark this internally on our data set and eventually fine tune our own models potentially. But if we aren't in touch with the problem, we actually don't have an internal way of benchmarking this, we would just have to be trusting these language model providers.
So sometimes information in the medical record is incorrect or inaccurate and has been cut and pasted or right and left inverted. How could you build in some safety and quality metrics in addition to the improved speed, which is great, and the improved revenue, which is also very great, but how could you use this tool to facilitate safety and quality and pick up avoidance of potential mistakes based on inaccuracy in the medical record?
Sure, I can speak to that. So when we were doing our manual grading, we actually noticed several copy and pasted notes throughout the medical chart. There's a specific example when a lung cancer patient had a quote left femoral metastasis. And when I was checking throughout the chart, there was no mention of radiation to a left femoral metastasis. When I actually checked the radiation oncology, the actual procedure summary, it was actually noted that it was a left humeral metastasis, not a left femoral metastasis. So I wouldn't have known that unless I went to check the radiation oncology treatment site, because every single note in the actual oncologist note said left humeral because it was a dictation error from M-Modal. So we're actually grounding every single grading system in ground truth data like pathology and radiation treatment site. So we're actually tracking every single note to see if there are any interval changes. And if it is interval change, like we would have to cross-reference that with ground truth data like pathology and radiation oncology.
To follow up on that point, we actually noticed many times where the language model got it right. And when we did this digging, we realized that there was some error. So it already kind of, since it has access to all of the information, tends to pull the right context if it's available to it. I think in line of developing these metrics for our internal benchmarks, it would be important going forward for us to look at, do you have conflicting entries for this one field? And if so, raise a flag for us to see or alert the clinicians who wrote the note.
Last point to this is one of our primary mentors is Andy Beerhals, who's our chief of quality and safety. So he's also been very influential in helping us, the reason that we came up with this product was not necessarily just to, increase revenues for the system. It's more of a nice side effect of it, but we really need this now in order to be able to get through our clinical workflows, get through our days and provide the accurate interpretations that we want for our patients that really take in all the different sort of pieces of data that we mentioned, rather than just saying, larger pulmonary nodule.
We have a question online, and this will be the last question that we'll take. And I think this piggybacks off of Dr. Frazier's question, but will this cause a bias of reading scans because of the summary? How might you answer that?
Yeah, I'll start with mine. Yeah, so the first way to answer that question is I think, I was a medicine intern here actually, and when I went into radiology, a lot of my friends were asking me, does clinical information that we provide, is it bias you? Like reading a scan is some sort of objective ground truth. But one of the parts of training to be a radiologist is there's a lot of subjectivity and a lot of other things that go into our sort of image interpretation to help the patient beyond the image. So that's why our workflow is basically involved all those different steps. So gathering clinical history is essential, like I mentioned, like in all the examples I mentioned, in order to come up with an accurate diagnosis. So I would say that more clinical history is always better for us. So that bias is not really a bias, but it's part of our process.
Yeah, I completely agree.
Good afternoon, everyone. It is my pleasure to present to you Bringing AI to the Bedside, Prospective Validation of an Automated Wide Complex Tachycardia Differentiation Tool. My name is Adam May, and I am the team leader for the team Diagnose VT Without Looking. So wide complex tachycardia differentiation, what is it? Well, you can essentially boil it down to this question. Is it VT or supraventricular tachycardia? Now, that basically entails, can you tell the difference between this ECG and this ECG? Now, why is this important? What are the clinical implications? Well, it has a lot to do with the path of care that you take. Implications include immediate treatment, care triage, diagnostic testing, invasive procedures. Now, what happens if you do this poorly or in fact do this wrong? Well, it can essentially lead to medical error. What about an actual VT misclassified as a supraventricular tachycardia? Now, this is a feared outcome to all of us cardiologists, and essentially it can lead to patient disaster, and that would include the untimely death of someone due to a medical error. What about an actual SWCT or supraventricular tachycardia misclassified as VT? Well, the implications are less severe, but it can lead to inappropriate external shocks, inappropriate device implantations, unnecessary invasive procedures, and then also increased healthcare costs and also increased psychological distress to our patients. So, because of the clinical implications and why it's so important, there has been greater than 5 decades of research into development of manual wide complex tachycardia differentiation algorithms. And these include algorithms produced by the greats of electrophysiology, including Hein Wellens, Josep Brugada, and others. Now, all these manual algorithms do rely upon the visual inspection of the 12-lead ECG, manual application of specific criteria, and absolute classification of a supraventricular tachycardia or ventricular tachycardia. Unfortunately, we've had disappointment with independent appraisals. These include modest overall accuracy, good sensitivity, but weak specificity, limited impact on post-test VT probability, and overall trouble ruling out and ruling in ventricular tachycardia. In essence, they were struggling to accomplish the set task of the very algorithms of themselves. So it's also a matter of practicality to us clinicians. I wish it were this easy. It turns out it's not. This is more representative. It's a learning curve with most clinicians at the very beginning. And essentially it's come to a point where there's an ever increasing minority of clinicians that are able to do this effectively. So we need new methods. We need methods that are highly accurate. We need methods that are simple to use. In other words, automated. And then we also need methods that are widely applicable and generalizable to all ECG products. And we believe that automated machine learning algorithms are the answer, using computerized ECG data for feature selection and feature engineering, plugging these into machine learning models to arrive at effective algorithms. We have already created many algorithms over the past 6 years, all of which demonstrated enhanced diagnostic performance for the task of differentiating ventricular tachycardia and supraventricular tachycardia. Now, the linchpinning elements of these algorithms, a lot of these have been protected by the United States Patent and Trademark Office mechanism. Now, we also retrospectively validated these algorithms with a recent publication that we call the Man versus Machine trial that was published just this past fall. Now, in this trial, we essentially compared manual methods versus automated methods. And what we found is that automated methods outperformed manual methods in terms of overall accuracy. Our next step is a prospective randomized control trial that would be conducted on a virtual learning platform, that being the EKG Guy, where we randomize participants into ECG interpretation with the wide complex tachycardia differentiation algorithm and without the wide complex tachycardia differentiation algorithm. And this is how it would be presented for the control. Users would be asked to interpret the 12-lead ECG, assign a degree of confidence, and then also and for the actual intervention arm, it would be the same process, except there is the application of the algorithm, which essentially provides a prediction of the likelihood of ventricular tachycardia. Now, we've done virtual randomized control trials before. This is an example of one called the EDUCATE trial that we completed last year. And in this trial, we were able to successfully enroll 1,200 participants to actually complete the study. Now, we believe the results will help us better understand the influence that AI has on the physician and ultimately help us get better at providing patient care, which is in a direct alignment with the Big Ideas program. And the results will also help us greatly establish regulatory approval, but also its commercialization prospects. This is our team. It includes individuals from GE Healthcare, Mayo Clinic, of course, WashU, and also the EKG guy. Thank you. Dr. Frazier.
So where are you going to pilot this? It just at BJH or all of BJC or across the country, or what's the plan?
So this trial will be conducted at definitely 2 sites, potentially more. One would be the Mayo Clinic and then also the WashU. We plan on obtaining IRB approval to actually recruit participants from both sites. Dr. Maddox.
There we go. I missed the gold standard by which you would validate the algorithm.
So these algorithms were evaluated according to an electrophysiology study or actual internal device recordings. That would be the gold standard for the actual RCT.
And maybe you can help just clarify for me. At the beginning of your talk, you talked about some algorithms that didn't work. And so specifically, what are you doing that's different that sort of gets you over why all of that didn't work?
Oh, perfect. So the original algorithms, the 50 years of work from electrophysiologists and cardiologists were manual algorithms. These algorithms are automated, and they are designed to provide the clinician a probability of it being ventricular tachycardia as the diagnosis. The other algorithms essentially have an absolute classification of VT or SWCT or supraventricular tachycardia. However, it has to be applied manually through visual inspection by the clinician themselves. This would be an automated approach.
Thank you so much for the opportunity to present our project to you today. First, we'd like to acknowledge our collaborators in this effort with representation from the Department of Emergency Medicine, Department of Surgery, Internal Medicine Division of Hematology, as well as BJC Patient Experience. Our work wouldn't be possible without the generous collaboration and participation of our community of sickle cell patients and their advocates here living in St. Louis. We'd also like to acknowledge our partnership with LogosNet. This is an Italian-based company that specializes in immersion-based simulation teaching to teach communication practices. We're working with them on their product, but have no financial stake in that company. Patients living with sickle cell disease carry a large burden of trauma, and this comes from their personal, familial, societal, as well as historical experience. This is due to a lot of factors stemming from their racial identity, long-term disability from their inherited genetic disease, as well as socioeconomic disparities. Nationally, about 66% of sickle cell patients seek care in the emergency department every year, and this is our local information for BJH from 2024. In total, we had 151 unique patients seek care in our emergency department with a total of 894 visits across a large spectrum of usability. And first, I want you to think about how often you or your family members have required emergency care in the last year. On average, this small subpopulation goes to the ED 6 times per year, again, with a large skew of use. And despite this high frequency of utilization, their experience in the emergency department is not positive. And that really mirrors the national experience. Based on previous data, 50% of sickle cell patients feel misunderstood, misjudged, and actually admit to avoiding necessary emergency department care due to their past trauma in the healthcare system. And these are real quotes from patients living with sickle cell disease who seek care, again, from previous studies. And these quotes are heartbreaking to read and are frankly unacceptable to us. So we need to do better. And the way that we want to do better is by teaching providers to adopt a trauma-informed care framework. Trauma-informed care is a framework that shapes healthcare providers' understanding and responsiveness to trauma by promoting safety and emphasizing empowerment of patients and their families to make their own healthcare decisions and regain some control. Our challenge is, how do you teach this? How do you teach communication and a general framework? And we think that simulation is an excellent tool to do this. Simulation-based learning is a very effective tool that has been highly studied in healthcare settings. But the problems with in-person simulation are twofold. They're resource intensive, and psychological safety can be a significant issue when you're practicing in front of a group. And this is where AI comes in through the incorporation of computer-based simulation training. AI-based simulation gives learners the opportunity to practice communication-based encounters in a psychologically safe environment with nobody watching. Compared to in-person, you can do this anywhere at any time and also can be built to scale because it's computer-based. There's also room for customization within the large language model that can be just built to fit whatever your educational needs are and whatever your learners' needs are. And this is the example of the product that we're working with, again, with the Italian-based company LogosNet. This is Mia, and she's the preliminary draft of the avatar that we're working with. She moves and she speaks like a real person and provides a transcript like the one that you see on the screen right. When you're interacting with Mia, she's immersed in a care environment. So in our case, that's the emergency department. And on the screen, you do see a live transcript of your conversation with feedback provided. These transcripts can also be downloaded for review by the learner, as well as by us as investigators, to evaluate the utility of this educational tool. So the LLM requires a frame, and Mia has already been given a frame of sickle cell disease knowledge, as well as trauma-informed care. But where our project is unique is our community engagement. We're actually involving patient narratives from the very community that has come to us, demanding that we improve the care that we provide, our population of sickle cell patients. Our project has 3 core aims and is determined to use AI-driven technology to teach trauma-informed care, specifically in our sickle cell patient population. Our first aim is integration, right? And this is integrating across the training platform that we have for BJC and WashU. But we're going to spend most of our time on aim 2 and aim 3. For aim 2, this is the optimization phase in which we conduct semi-structured interviews with our community of patients and their advocates and put their transcripts into the LLM to provide an aggregate and realistic lived experience of sickle cell disease. We're then going to pilot the program with our population through a series of focus groups to ensure realism, authenticity, and accuracy before it's deployed to learners. In aim 3, this is an educational tool, so we have to assess its educational impact. In this pilot phase of our study, we're going to be working with resident learners. We have 56 learners in our emergency medicine residency program, and we'll be using a Kirkpatrick framework to assess the efficacy of our project. Reaction and learning will be assessed by a post-simulation learner survey. Behavior is going to be on a 3-month standardized patient encounter, again, to assess for knowledge retention and translation to another scenario. And then results can be looked at in 2 ways, through patient experience as well as ACGME milestone performance. So our initial work is really focused on optimizing the product and then feasibility and integration. But where we're really excited is that the future directions for this are effectively infinite. You can change the learner. You can change the type of avatar that you have a focus on to represent different cultures, different abilities, different scenarios that have high-risk communication. You can provide targeted education to providers that need it, not just residents, but nurses, faculty. And then ultimately, if deployed across a large spectrum, you can improve patient care by improving the patient experience, which will lead to better patient and provider satisfaction. And with that, I'll take your questions.
Thank you. What a great project. When you talk, can you talk a little bit more about the observed patient encounter? Communication is so subjective.
Yes.
And is there a component of return demonstration based on what's learned in the AI teaching tool?
Sure. So within the AI frame, LogosNet works with a team of, and this is sociologists, anthropologists, as well as psychologists. So the LogosNet sort of product already has an understanding of communication practice. And what we've added to it is the TIC grade assessment rubric. And this is a validated tool from the patient perspective that comes from the University of Michigan. And so the TIC grade tool has been put into the AI software. And then the same tool will be used by our trained standardized patients to assess the encounter. So we're hoping that we actually, by using the same assessment strategy 3 months later that we remove a little bit of that. To your point, observation bias, it happens, and that's something that's unfortunately unavoidable. Standardized patient encounters are commonly used, and our students are used to it, our residents are used to it. This is how people are learning. However, again, through training, we do hope to just, sorry. We hope to just try to mitigate that bias as best as we can. I can hear you. I can repeat your question. Correct.
What you're doing and looking at the population, I think is tremendous and it's a tremendous need. I'm just curious what that looks like from expanding care and helping the guidance.
Sure. And so by the numbers, best estimate, I think we have about 350 children and about 450 adults living in St. Louis with sickle cell disease. Right now, because of the community-based engagement piece, we'll be participating with adults. We have to interview them with their consent. Families are also represented in the advocacy piece. We're choosing an adult patient scenario because it's a one-to-one communication dynamic. So Mia can represent one person. I think that the avatar would have to be customized a little bit differently to deploy to pediatrics, where you have both the patient that you're caring for, potentially a small child or adolescent, as well as the family that are represented. Again, trauma-informed care is about holistic care and involving families, but I do think that that would be an easy adjustment that can be made. And LogosNet offers a lot of customization as we're just, again, starting to explore this tool and what it can do. So time frame, I mean, after the year, we're really focusing on this pilot, but again, we're excited about the possibilities for expansion, and that would be a brilliant one.
Is the patient experience that they're talking about only when you get in, because you're looking to sort of test this with residents?
Correct.
But is the experience, this negative experience, sort of start when they first enter at the ED? And so it's more than just the residents. So why are you just looking to start with residents and not a more holistic experience?
Sure. So you're correct. I think that there are a lot of frustrations, both from the point of entry and wait times, as well as interactions with kind of frontline nursing staff and expectation management about when they're getting back. There's frustration from the provider standpoint, and that's partially why we chose residents in terms of the conversations about pain control. We chose residents from an academic standpoint for two reasons. One, we can integrate this into their curriculum and do think it will be a valuable add. And two, they are a defined population that so far is relatively homogeneous. They're of similar age, similar background, and similar experience in healthcare. So from a study of the tools standpoint, we thought it would be the perfect pilot. Our hope is certainly to deploy this department-wide, because we realize that we have significant need among our nurses, our technicians, and have had didactic sessions, collaborations with Dr. Safe and hematology in the past to teach some of these principles on a larger scale, but we have to start somewhere with the sim.
So can I just do a follow-up? What if you saw no difference and really it was, the change needed to happen sort of on entry, and that experience is carried through no matter what the clinician change might be?
Sure, and that's a possibility. I think from a customization standpoint, you can then still take the same frame, the same knowledge of trauma-informed care, the same knowledge of the disease and the experience, and potentially you can move Mia from an exam room to the waiting room and really kind of manage that front-end type of communication of why am I waiting? I'm in pain, I'm coming to you for help, and how we can validate that experience better while addressing other systems issues that are contributing to the back-end experience. But I do think that the tool would be customizable in that sense to address, again, if no difference here, can we tweak it and maybe find where the problem is? So diagnostic as well as hopefully improving those outcomes through teaching. Thank you.
Okay, so hi everyone, I'm Jonathan Moran. I'm an MD PhD student here at WashU doing my PhD in the Biomedical Informatics and Data Science program. And I'm here to get your help in us using large language models to drive quality improvement in surgery. So what is the problem at hand? Surgical site infection, a type of hospital-acquired infection, can usually be treated with antibiotics, but in some cases may require more complex clinical care. Although some surgical fields have reduced the complication to low single digits, the complexity and location of hepatobiliary surgeries makes this issue harder to address in this field, with prevalence as high as 25% in some cases. We believe the data necessary to address this issue lies where most clinical data is already found, within unstructured clinical notes. Not just surgical notes, but infectious disease, nursing, hospitalist notes, just to mention a few. The importance of unstructured data has been recognized such that the American College of Surgeons has created a data registry known as NSQIP that sources data commonly curated from unstructured clinical notes and is highly relevant for surgical outcomes research. However, most of this work is done by manually human extractors. Here at BJC, even with the great work we do, our extractors only get to around 3,000 cases per year, which is roughly around 20% of eligible reportable cases to NSQIP. So what then is our goal? We aim to use large language models to automate the data extraction process, thus allowing us to focus on leveraging this curated data for research and to improve patient care. We've identified some ways in which our project aligns with some of the core values at our institution, such as by increasing the amount of data available, we can augment our data analytics, thus improving outcomes for patients and their families. LLM implementation can complement the work done by our BJC abstractors, thus creating a human-in-the-loop system that can eventually evaluate up to 100% of cases reportable to NSQIP. Also, WashU is uniquely positioned by having both the technology and the expertise to push forward a project of this matter. We can be leaders in surgical quality improvement innovation. I, alongside other members of our team, have proven experience extracting clinical data from free text using large language models. Here, we simply show a visual example of free text data that is identified, extracted, and categorized by such models within the context of lung cancer cases from some of our previously published work. Although again, here in the context of lung cancer, our team has built and deployed architectures to extract clinical information from other contexts as well, such as different neurodegenerative diseases, Alzheimer's, head and neck cancer, amongst others. So we are ready to leverage the use of large language models in a HIPAA-secured environment to extract clinical data in this surgical context. Our group has also previously shown that large language models outperform traditional rule-based natural language processing models when it comes to extracting clinical information. From these two graphs right here, we look at the two rightmost entries, we can see that traditional NLP models underperform when compared to large language models in extracting clinical data. So for this reason, the future of clinical data extraction lies contingent with the use of LLMs, given that this is the current high-performing standard. Our group has the expertise to evaluate the performance of large language models, to follow a data-driven approach in addressing our main issue of extracting high-quality data to find insights into surgical site infection. So how will this workflow look for this project? Our clinical and quality improvement team will identify surgical cases within our hepatobiliary service. We will use large language models to extract both structured and unstructured variables relevant to the identification of surgical site infection. For our validation step, we have access to years' worth of surgical cases curated by our BJC abstractors. That will serve as our gold standard for all performance assessments. This work will present better data sets to evaluate differences between patients who develop surgical site infections and those who don't. thus facilitating the future identification, management, and prevention of this complication. This data can then be disseminated to national databases, increasing WashU's contributions to surgical outcomes research. This work cannot be made possible without our multidisciplinary team of surgeons, bioinformaticians, and clinical quality assurance supervisors. So in the end, medicine has many challenges, and a vast amount of data sits untapped, waiting to be a part of the next breakthroughs. Our project focuses on bringing some of the most crucial clinical data to the forefront of discovery. Thank you for your time. I'm happy to address any questions. Yeah, so here on the stage, we have Dr. Zachary Abrams and Dr. Dominic Sanford, also parts of our team, to help address any questions.
Yeah, thank you for the great presentation. I have a question. Can you just elaborate on, I feel like the clinical nose extraction and improve the quality of surgical recovery is two kind of separate questions. One is unsupervised by the labels. It's like you are just using the nose for the extraction. The other is leveraging the particular downstream tasks for the models so that you can let the language model to decide which are the texts or the notes you think is important. So I'm wondering during your training process, or are you kind of just extracts the fixed kind of ideas that you think are important, or you are using like the data-driven methods to let the model to get attention to those kind of notes that the model think is important?
Thank you for the excellent question. So we would first be leveraging the large language models itself to be able to do the extractions in the format that NSQIP currently does with all of their approximately 150 features. Once we are able to actually get that massive increase in our sample size by leveraging all of the potential surgeries that would be involved in the surgical site infections, we can then look across those 150 features to identify whether or not there are differences within those that help separate out our two populations. So we're not necessarily asking the language model to do sort of a class prediction assignment directly itself, but rather leveraging it for what its more intended purpose is, which is pure data extraction. Thank you.
I'll just add into that too. You know, NSQIP is the gold standard with regard to surgical outcomes and surgical quality measurements across the country. And it's rigorous and well validated, but it is extremely resource intensive. So kind of step one is, you know, getting it to where we can really look at all of the data that comes out of the institution. And the implications of this, if we're able to pull it off, I think are massive, not just here, but across the country.
So are you going to apply these large language models while the patient's still an inpatient or after discharge? And if so, at what time period after discharge?
So all NSQIP data is gathered 120 days after a patient has had their surgery, and it follows them for 30 days, but their data is not gathered until 120 days after.
And what variables are you going to look for that would be predictive of a surgical site infection?
NSQIP captures a tremendous number of variables, everything from obvious things like age, sex, race, comorbidities, to functional status. And there are specific factors within the actual surgery that took place. So it's really, there's a lot of different variables in there. In the sense of like looking at more common type operations. Yeah, it's a great point. I will say that here at BJH, we do, you know, there is a fair amount of still bread and butter general surgery cases, gallbladders, hernias, that sort of thing. But your point is well taken. I think part of the nice part about here is NSQIP is also at Barnes West County, as you know, and Missouri Baptist. So kind of as a first step to validate it with a large number of patients here, that would be a logical next step for sure.
I would also like to add that in our idea is to make a human in the loop system where the LLM isn't just automatically running the entirety of it. It is a complement to the work our BJC abstractors currently do, and they have huge amount of training and actual manuals on how then to tackle those complex cases, especially when there comes to some incongruent, disagreements between what different parts of a patient's record might say. They are actually trained on then how to get to one, decision to then feed into the database.
And as a final point to that, one of the great things we can do with language models is we're not simply asking a language model to extract, age, et cetera. We're able to leverage the knowledge that our abstractors had to actually build out effectively like a knowledge graph of what are the decisions that they make and what is the information that they need from this particular type of note, and all of the information that they have at their disposal for how do they do their job to the high quality that they do. And so we're able to actually take that and effectively have the language model try to act in that setup. This also means that importantly, the language models are able to point to where they actually pulled information. And so that way it makes the human in the loop able to actually effectively audit what the language model is providing to them and say, okay, is that information correct? And also, where did you get it from? And is that from the correct type of note? And so that way you keep that human being able to actually oversee whether or not there was a hallucination potentially involved, et cetera. And that human creates those effective guardrails.
Can you hear me? Okay, great. I want to commend you for finding a way to allow other centers and patients to benefit from your intervention. I think one of the limiting factors of AI in healthcare is that we so often have only our own population to study because of HIPAA. We're firewalled from the opportunity to learn from others and others to learn from us. So I thought that was really unique and very cool. My question is about human error and about controlling for error in your model. I think an earlier presentation mentioned that their model could recognize a potential copy and paste. The charting is only as good as the people entering it and then the abstractors who can recognize it. So it may not be fair to expect a model to recognize an error that an abstractor may or may not. I mean, hopefully with experience they would, but could your model recognize or ignore errors in documentation in the medical record before it gets to NSQIP?
So excellent question. There are effective frameworks that you'd be able to employ and we would be able to employ here where you're trying to set effective boundaries on certain values. One of the best parts about NSQIP is that because it is so highly curated, we know exactly which features they are looking for and what potential range setups there are. So you'd be able to identify whether or not this particular value, let's use a simple one as, for example, patient age, whether or not age shows up in multiple different places at different values. If so, is there a reason for that in regards to the timing of those particular notes? And so you can build out that type of decision-making is actually what the human abstractors currently are able to do. And so you can build that rule set into effectively the knowledge framework of how the LLM is going about trying to pull the extractions. We will never be able to get away from sort of a garbage in, garbage out problem of if you simply always put the patient ages wrong, there's no direct way even through context clues that you'd be able to fully pull that out. However, we don't believe that this is ever garbage. So we're dealing in a very high quality data format to begin with, but we would be able to build in those same types of guardrails that are currently used by our abstractors.
Yeah, there also wouldn't be any worries in sense of what data from the large language model would be pushed out of the institution, because in the natural way that NSQIP works, they also go through the human curation process, and those human abstractors also have to abide through some quality metrics to have data from your institution be able to be pushed into the national database. So they're on top of the already established guardrails by NSQIP for their data that gets inputted into them. Then we can also impute our own for the model and essentially have coverage all around.
My team and I are excited to present our real-time quantitative blood loss measurement for early hemorrhage detection with a novel wearable device. And we have the following financial disclosures.
So the problem we're going to be talking about today is postpartum hemorrhage. Postpartum hemorrhage is defined by excessive blood loss following delivery, and it's the leading cause of maternal mortality and morbidity. Fortunately, it's also noted as the most preventable cause of maternal death. Prevention of postpartum hemorrhage is highly dependent on early diagnosis and treatment initiation, as well as accurate blood loss monitoring throughout hemorrhage. So currently, the methods for monitoring blood loss are through visual estimation, in which we can just look at how much blood is pooling around a patient, and more quantitative blood loss estimation, in which we'll weigh blood-soaked sponges and dressings, or use more volumetric blood collection canisters. So these methods cannot detect any internal bleeding. They cannot distinguish between amniotic fluid and blood. And they're also typically only done at the end of a delivery. So it's not a continuous measure of blood loss. So this can't provide an early diagnosis or accurately monitor blood loss throughout. At BJC, hemorrhage or PPH, death due to PPH does not occur in high rates. However, the prevalence of PPH has almost doubled in the past 3 years. So we've had a steady increase in the amount of PPH, and now in about 15% of deliveries, PPH will occur. And when PPH occurs and it doesn't lead to a maternal death, it can still be associated with severe complications and maternal morbidity. So why is early detection so important? So let's talk about kind of the timeline for PPH progression and intervention. So if hemorrhage is caught in a very early stage, we can treat that hemorrhage with a uterine massage or medication. These are very low cost and like low risk techniques, and they can be successful. And within just minutes, the hemorrhage can progress to a very severe state where the patient may require a blood transfusion, surgical intervention like a hysterectomy. And these techniques are much more high risk, as well as requiring more resources and higher cost. So if we are able to detect hemorrhage in an earlier stage, we can prevent maternal death, morbidity, and save the hospital valuable resources and expenses. And it's also really important to note that monitoring this process in real time and continuously is very important because it can happen so quickly.
So our team is proposing a wearable continuous monitoring blood loss quantification device. And you can see the device here, and actually Kiki is wearing it on her wrist right now. And this technology uses something called laser speckle imaging. And this is a relatively new technology that in standard research labs is on a benchtop. And our team is one of the first in the world to miniaturize this into a wearable wristwatch form factor, which you can see. And laser speckle imaging specifically measures changes in flow or blood flow. And so it is also a very high signal to noise ratio method. And hopefully you can appreciate here, we have these really nice pulsatile waveforms, lots of contrast, really high SNR. And so this is a big advantage over the standard monitoring tools such as pulse oximeters or that technology that they use, photoplethysmography. And so this is a big innovative benefit for our technology. And so we get these nice waveforms, we can extract features from them, put them into machine learning models and actually try to estimate how much blood loss has occurred for a given set of waveforms. And we have actually done this, and we believe we are the first to actually use this sort of time series data to make a blood loss prediction. We have tested this in a swine model of hemorrhage in which we trained a model with just 2 of the swine and used their data to predict a third. And you can see that at the baseline, our predictions were very close to 0. And then during hemorrhage, our estimations went they changed almost immediately and were very close to the actual true blood loss that was measured. And again, at recovery, we kept close to a stable position. But this is all great. However, These models were done about a month after the surgery occurred or the procedure occurred. And what we need clinically to actually help patient care is a system that can be done in real time and provide this information in real time. And so with funding from the Big Ideas competition, we would propose pairing our wearable device with an interactive tablet that would be able to compute the LSFI signal in real time and also make this blood loss estimate in real time. Then we would be creating a graphical user interface here. You can see they would be providing the waveforms to the clinical team so that they could look at the quality, just like they already do for the vital signs that are in the room. And then also provide a quantitative blood loss estimate that would be updated approximately every 3 seconds so that the team would know right away when a patient is nearing a dangerous amount of blood loss. And then we propose validating this new rapid algorithm and tablet display data in a human blood donor model. We are joined by an incredible team of collaborators with expertise in biomedical engineering, machine and deep learning, dermatology, computer science and engineering, obstetric anesthesiology, and high-risk obstetrics and gynecology. And with that, we are happy to answer any questions.
How well does the device work for people of different skin tones?
That's a great question. So we have tested this extensively in our research lab. And what we have found is that the signal intensity does decrease in darker skin tones. However, the morphology is maintained. And so we have done a number of human volunteer studies, and we saw absolutely no difference based on skin tone when we were trying to predict things like blood pressure, cardiac output, systemic vascular resistance, et cetera. And we are also, we haven't done this yet, but we are actually going to be testing this technology in a bicolor swine model where they have a darkly pigmented wrist and a lightly pigmented wrist so that we can have the exact same physiology and know for sure that we are not having any sort of bias like what has been seen in the pulse oximeters. Additionally, the fundamental technology that we're using is a light scattering method as opposed to a light absorption method. And so because it's based on scattering, it is inherently much less affected by skin pigmentation. So those are all factors that make it very, very unlikely that we would be biased based on skin tone. Great, great question.
Does everybody get this device?
So we have spoken with a lot of clinical stakeholders, and the problem with postpartum hemorrhage, there are lots of risk factors, but over half of the patients who have a hemorrhage don't have any risk factors. And so we envision clinicians wanting, if we can make this simple enough, inexpensive enough, the workflow, seamless enough that they would have it on every single patient. So I think in an ideal setting, the answer would be yes. And we're also, again, this is beyond this, but we're working on adding other vital signs such as continuous blood pressure, et cetera, which I think would also be much more attractive in terms of putting this device on every single patient.
Excellent presentation. My question relates to the features that you're using to identify patients with hemorrhage. My question is, do you have a delta from the baseline to the new baseline after hemorrhage as part of your feature development for your modeling, or is it just in real time?
Yes, and I'm going to let the experts on the exact feature mining answer this question.
Yeah, so are you talking about kind of like normalizing between patients or just in real time?
Perhaps it's best framed this way. So you have a baseline patient, they bleed, and then they have a new baseline. Are you using kind of the delta between those timeframes to develop features for your modeling?
Yeah, so actually, like when we initially started this project, I was just using like exactly what the value was. But as I've kind of been progressing, I've started using like a baseline as a way to actually track the delta, and it's shown that it's more accurate that way. And I think it's very feasible that in a clinical setting, you can have some sort of like 5-minute baseline measurement where you get this standard measure for a patient, and then you can track from there. But both methods actually performed well. So the data like that Dr. O'Brien showed today actually was without this kind of like baseline normalizing.
So are you proposing to do a randomized controlled trial of this in postpartum patients, or do it as a cohort model where you put it on everybody and then, use the non-bleeders as the controls, or what were you thinking in terms of future study design?
Okay, yeah, so as long as we're talking about future studies. So in this proposal, we're just talking about a human blood donor model. But yes, in the future, we envision at first an observational study alone. So making sure that we are able to collect the data, we can tune our models specifically for obstetric patients. But then in the future, we would be doing a model of both cesarean delivery and vaginal delivery, where the real-time quantitative blood loss would be shown. And then there would be essentially a decision tree of the different interventions that the team would perform based on the output. And then we would compare the outcome to patients who are not having any sort of wearable device intervention.
So my name is Chris Abraham. I'm a radiation oncologist here by clinical training and an informatician by passion. And I'm joined here with my co-PI, Dr. Schmidt, who is a medical physicist and is the chief of our quality assurance program in radiation oncology. And we're here to talk to you about Clinical Trials API, web services for modern radiation oncology. So the radiation oncology landscape. Greater than 50% of all cancer patients receive a course of radiotherapy in their cancer journey. And the standard of care with which each of these patients are treated was determined through randomized clinical trials. But unfortunately, radiation oncology clinical trials are inherently complex. Each trial stipulates criteria to maintain protocol compliance, but this criteria is very diverse. Structure naming, structure segmentation, radiation dose constraints, planning rules, delivery rules, imaging rules, and within each protocol, failure to adhere to these criteria is listed as a protocol deviation. Unfortunately, protocol deviations are common, and these have significant consequences. So one paper looked at the median rate of protocol deviations in modern radiation oncology and found that that rate was 32%. Another meta-analysis looked at 8 modern radiation oncology trials and found that protocol deviations were associated with a twofold increased risk in local failure and mortality. And as we move to a more multimodality concurrent care delivery system, protocol deviations not only impact one patient, but all patients and actually the entire oncology continuum as a whole. So for instance, as we're moving new agents from the metastatic setting up into the concurrent chemoradiation setting, you can see that a good efficacious drug can result in a negative clinical trial due to bad protocol violations from a radiation therapy perspective alone. And pictured on the right here is just a small snippet of one trial. And in fact, protocol constraints in this trial occupied 4 pages. So why so many deviations? So radiation oncology clinical trials are antiquated, okay? This is limited to printed PDFs. So a cooperative group like NRG releases a clinical trial. That clinical trial is opened at our institution, patients enrolled, placed on an arm, and our planners take that PDF, print it, and then enter that constraint criteria into our treatment planning system. Or some instances, they just reference the PDF document and look at the final plan. So modern radiation oncology trials do not have any centralized version control. There's no standardization. There's no feedback loop amongst the cooperative groups or the enrolling sites. There's no automation. There is no force multiplication. And based on how these clinical trials are interpreted, there's a high inter and intra-observer planner variability. So we aim to solve this problem by modernizing radiation oncology clinical trial delivery. So the first thing that we aim to do is to develop a cloud-based repository of clinical trial constraints. We aim to do this by leveraging LLMs to extract protocol constraints and develop relational databases on a per trial, per arm basis. We will develop a user interface to allow for human-in-the-loop evaluation of these extractions to verify that they're correct, but also to grant access to enrolling sites and to maintain version control. After that's done, we'll deploy an API that'll allow enrolling institutions to pull this constraint data into their treatment planning systems. These API queries will provide all necessary compliance thresholds and planning constraints to the end institutions. One of the extra benefits here is this will allow support for scripting environments, so you can actually generate radiation therapy plans even faster. And then lastly, we'll evaluate this by looking at protocol compliance improvements, such as reduction in deviations, time savings, patients receiving radiotherapy faster, as well as user satisfaction. The reality is that the impact here is significant. This is a foundationally transformative innovation in radiation oncology. And a more graphical picture is here. So we would basically take these clinical trial documents, parse them using LLMs, develop a relational database, and then which would be depicted here. So it would provide naming structures, segmentation constraints, all of the dose constraint criteria that can be adjusted via an API into the treatment planning system. Our research team here, Radiation Oncology Web Services, is pretty diverse. That's okay. Is diverse. We are experts in clinical trials, scripting, LLMs, and two folks that aren't pictured here, didn't have a picture of them, are experts in protocol compliance measures. So.
Great presentation. Deal with treatment variation, like length treatments, treatment start, which has a very significant impact on outcomes.
So what's not pictured here is what we've done in modern radiation oncology to try to reduce this. And what's happened is all of these cooperative groups have said, submit your plans to us, we review them, and we will say if this is compliant or not before patient starts. The unfortunate reality is that has led to longer patient starts. And in fact, I treat CNS malignancies. My colleague and I actually stopped enrolling patients on a trial because it was taking too long. So with this, the fact that you can ingest all of your constraints instantaneously, have centralized version control, will allow patients to start faster. The other piece that's also not listed here is we intend to actually have a phase 2 for this project, to where instead of you submitting the plans to the cooperative group, someone physically sitting down and reviewing your plans, we will ingest your plans back into our system and verify the constraints were not changed. And then we can submit that to the cooperative groups to say that this passes and this is a protocol compliant plan. And then the other piece to that is if we're ingesting this information, we actually want to take all of the radiotherapy plans and develop radiation treatment models. So we wait to see that when the trial matures and an arm wins. If arm 1 wins, we will have all of the treatment plans housed in our system. We can develop a model, and then any institution anywhere in the world can treat as per protocol on the winning arm. So we won't have to wait for 5-10 years to see the practice change to the positive clinical trial. It can happen overnight.
So my question is, if this is the way things are done everywhere and it's very widespread, what are the cultural barriers that you have to overcome to actually implement what you're trying to do?
Yeah, so that's a good question. So I think for cultural barriers, I think anytime we talk about new technology, I think there's apprehension. But the reality is that this technology, while novel in this application, is actually not novel at all. And in fact, everybody's cell phone, this is how your weather app actually works on your cell phone. It's an API call. All of the modern treatment planning systems actually already have this built into them. So we're leveraging things that are already in existence, just using it in a new way. So I think from a radiation oncology as a field, like from a technical perspective, I think we're all on board with this. I think it's maybe just getting some physicians a little bit more comfortable with this. But I think as time goes on and we see LLMs like today being used in a larger context, I think that comfort will come with time.
Hello, my name is Braxton. I'm a medical student, and I'm excited to represent our group to talk about our plan to leverage machine learning to improve rehabilitation and surgical outcomes. For some background, SPAR is WashU and BJC's rehabilitation program, which means that they target older, high-risk surgical candidates with 4 domains of interventions: physical activity, respiratory fitness, nutrition, and mindfulness, in order to make them better, more fit candidates for surgery. And in this graph on the right, you can see that SPAR patients do better than their matched controls. Our problem, though, is that some SPAR patients are getting left behind, and we can't predict who. Part 1 of this problem is that we have very poor predictive ability in general. When we look at risk factors for SPAR GI surgery patients, we notice that some, like dyspnea, are potentially modifiable. And we wonder, could it be mitigated with better quality prehabilitation? But part 2 of this problem is that we don't know what constitutes high quality prehabilitation. But luckily, all SPAR patients receive a wearable device, Fitbit, that allows us to have a huge untapped source of activity data to begin to answer these questions. In prior work funded by Big Ideas, members from our group began the effort to use wearable device metrics to predict post-op outcomes. In this ROC curve on the left, you can see the predictive value in less than 4,300 steps in predicting severe post-op complications. And in an RCT showed that step count could be modified with enhanced intervention. And you can see that with the middle plot on the right. Our group took this a step further and created a pipeline for developing a machine learning model to predict post-op outcomes. And this work received a Distinguished Paper Award for its quality. On the left, you can see a list of several metrics that show that we can capture with a high degree of granularity activity patterns like sedentary bouts, heart rate variability, and several others. It also manages incomplete and missing data very well, with the orange trend lines very similar despite the left panel having a significant amount of missing data. It was very high performing, but it was trained on a low sample size and only a single surgery type. So for our first aim, we would like to optimize this machine learning model and scale it to all SPAR patients. First, with a retrospective cohort of about 650 patients who have already undergone SPAR and surgery. They've undergone a wide variety of surgery types, and the outcomes that we'll predict are 30-day mortality, readmission, and non-home discharge. We'll test a range of machine learning models listed below, and the best performing model we would like to test on a prospective cohort of about 150 patients enrolled over the next year. Once we have a working model for AIM-2, we'd like to identify the highest risk SPAR patients and characterize what low quality prehabilitation actually looks like. So first, we need to determine which patients have higher rates of adverse outcomes. Then we want to identify which activity metrics are most highly associated with adverse outcomes. And we did this previously with our last machine learning model, where we could see which metrics clustered with patients with complications and which did not. And we can look at this closer and see which of these may be modifiable and a target for future intervention. This allows us to determine what low quality prehabilitation actually looks like. And third, we want to see if there's evidence that poor prehab is associated with adverse outcomes in high-risk groups. And that includes 1, do groups with worse outcomes have worse activity patterns on average? And 2, within a high-risk group, do the patients with better activity have better outcomes? Achieving AIM-1 would allow us to improve patient selection alone, but achieving AIM-2 would tell us how to intervene. That's who to target, the high-risk groups, and what to target. That is the activity metrics associated with complications. It could be implemented like a simple web tool, like the ACS Surgical Risk Calculator, a very commonly used tool by surgeons today. So now imagine an older, high-risk patient who needs surgery. So they get referred to SPAR for optimization. They get their wearable device, and the surgery team may look at their post-op predicted risk with the NSQIP calculator, which is what is done today, but that's as far as that calculator will go. As they accumulate activity data, that data can get combined with clinical data, and our model would then allow a new risk prediction to be given. If the model predicts a high risk of adverse outcomes, that would signal a need for enhanced intervention, such as modifying specific activity patterns or something else. And an exploratory aim of this work would actually be to define an enhanced intervention for future clinical trial. As they continue through prehab, the team can check in on their updated risk, and if the model now predicts a low risk of adverse outcomes, the surgeon may decide to proceed to surgery. Or if the model is continuing to predict a high risk of adverse outcomes, they may decide against surgery and choose non-operative or continued or modified prehab options. This would be one of the first surgery risk calculators to provide continuous risk assessment so that we can incorporate real-time data into surgeon decision-making. Our team is composed of expertise in both clinical and technical domains, with Dr. Sanford as the Chief of HPB and Director of SPAR, and it'll be crucial for the clinical and practical implementation of the model into SPAR. And Dr. Liu is renowned for his work in machine learning in healthcare, and he'll be crucial for successful development and scaling of this model. Achieving our goals will facilitate improved post-op outcomes, delivery of cost-saving interventions, empowerment of patients to take over their own health, and advancement of healthcare equity to target those left behind. Importantly, our proposal is feasible, clinically useful, and a novel strategy to leverage machine learning to improve healthcare. Thank you, and I'd be happy to take any questions about our proposal.
Thank you for a great presentation. You mentioned health equity as a target, but how will you measure the impact of socioeconomic status or the social determinants of health upfront in the group that you're measuring?
So lots of demographic factors are captured with the clinical data that we import into model development. So we can see how outcomes change with demographic status, and those may be groups that would be better targets for enhanced intervention. Also, there's work underway to look at how socioeconomic status is impacting the implementation of SPAR and how SPAR outcomes and SPAR adherence to the interventions are mediated by socioeconomic status and those types of factors. Yeah.
Thank you. Great presentation. I think it's related to your question. Can you say a little bit more about in the model build, how you tackle the question of model fairness?
With this model, I think that right now the data is best. The best interventions are physical activity in predicting post-op complications. But because the machine learning models, and there's a long list of them, they can learn from little nuances in different patients. And when different patients have different groupings of comorbidities or different groupings of age, sex, race, things like that, that would allow the model to be able to identify those types of patients, and it actually would advantage those patients if they're being predicted at a higher risk to be able to receive these enhanced interventions.
I can add more to this question. I think there are two strategies we are going to handle it. It is definitely a very important question. The first one is that we are going to incorporate features into the model, like the race and social status of the patients, so the model can learn from the distribution and take that into account when make decisions. The second one is that we are going to use more advanced machine learning models that are specifically designed to tackle the social and group fairness. For instance, we are going to do some reweighting of the models when the model learn from the representations. Easy way will be to use fancier sampling methods and to generate data from the minority group, so the model can learn better about the overall distribution when making decisions. Thank you.
All right, I'm all that stands between you and being done and moving on with your day. So first, I just want to say thank you to all the groups that presented. You might not appreciate this, but Tom and I were talking about this during presentations. This has been a phenomenal set of teams, really amazing projects. And on a personal note, on a personal note, I just want to share, I actually got up at 2:30 this morning to get on a flight from San Francisco to make it here in time for this. And at no point did I get tired during any of the presentations. So I want you to take that as a positive. So with that, just a couple of points. If the font isn't big enough for you, we will be announcing the winners the week of May 5th. And I do want to encourage everyone here, in addition to our esteemed panel of judges, to make sure that you use this QR code and that you vote. And there's sort of a reminder there about all of the key dimensions that we're asking you to vote on and the voting scale. So please, if you haven't already done that, use the link, put in your votes, and we do actually look at them when we evaluate these proposals. So it is not a clever trick to keep you engaged during the presentations. We really want your data. This is a giant picture of my head, so that's fantastic. So I just wanted to reflect very quickly before we wrap up. You know, I think Tom and I talked a lot about the theme for this year's Big Ideas competition, and I think the teams outperformed everything that we expected. We basically had a spectrum of proposals today, and I tried to think about sort of how we might summarize. It was a little bit difficult on the fly, but we really looked at projects across a spectrum from, how do we use simulation and precision approaches to coaching and training and education. And I really like these concepts of not just traditional education, but also coaching and more sort of practical, just-in-time solutions. We also heard a lot about how we can use predictive models to drive more precise therapeutic planning and really clinical decision support, especially in some high acuity domains where the risks and benefits are particularly substantial. It would not be an AI-focused event if we didn't talk about large language models, and we spent a large amount of our time talking about that, especially in terms of information extraction and summarization from the EHR. And then lastly, I would just say, this idea of going beyond just algorithms, but how algorithms in conjunction with devices, whether that be sensing, video, wearables, et cetera, allows for us to get that more holistic picture of what's happening to our patients and importantly, our providers, and improving the health of both. So I think it was a really impressive demonstration of all the innovative thinking here at both WashU and BJC, and I'm deeply appreciative of that. It's actually going to make it very hard for our judges and our panel to select the finalists. And so before we just sort of finish, I also want to thank in particular Lindsay and the rest of the lab team and all the other folks, including from I2DB that supported this. That's the sort of example of where all the important work happens behind the scenes. So I really do appreciate all of their work to organize this. And with that, I'd just like to thank everyone for joining us, and we'll see you again next year.